All right, guys, so we talked about the absorption of a drug. So we take a drug via one of the administered routes. The process by which the drug moves across particular membranes when it's not given IV gets into the actual bloodstream, the systemic circulation. So the process by which the drug moves into the systemic circulation is absorption. We talked about all the different factors that are influencing absorption, including the most important one, bioavailability, and the most important subpoint of that, first pass metabolism, okay? Now what we have to do is, now that the drug is in the bloodstream, now we need to do is talk about what happens to that drug. How do we get that drug that's in the bloodstream to be distributed throughout the body to the different tissues or organs to exert its particular effects? That's what we need to talk about now. So when a drug is distributed, right, so we're taking this drug from the actual bloodstream, it's in the systemic circulation, it's going to get passed off to these different types of organs. So it's got to move out of the bloodstream into these particular tissues. That's the distribution process. There's many different factors that influence distribution. What is that? First one, blood flow. There's so much variation in blood flow naturally. So some organs get a little bit more blood flow and other organs get a little less blood flow. It's a very straightforward concept. So what organs would have an increase in the amount of blood flow? Pretty straightforward, right? So for example, your kidneys would get a lot more blood flow, the liver would get more blood flow, the brain would get more blood flow. So if there's an increase in blood flow to these tissues, theoretically, what would happen to the distribution of the drug there? You'd likely, potentially, depending upon other factors, may have more distribution of drug to these areas because you have more blood flow that's carrying the drug. Opposite situation here is other organs have decreased blood flow. So when you think about this, it's only one factor. So remember that just because a patient has a lot of blood flow going to a particular tissue doesn't mean that that drug is going to escape into the tissue. So there's other factors that influence it. That's all this crap that I got to talk about. But if you have more blood flow, theoretically the distribution will be better. If you have decreased blood flow, theoretically the distribution to that tissue will be decreased. So you're not going to be able to deliver as much drug because you don't have as much blood flow delivering that drug to the tissue. So this would be things like the skin, the adipose tissue, things of that nature, okay? So when we say increased blood flow, we're talking potentially a theoretical increase in distribution. And whenever we say a decreased blood flow to a particular tissue, we say there's a theoretical decrease in the distribution. But again, that's just one of many factors. Now, I think one of the important things to think about this clinically is if a patient has some type of shock state. So for example, a patient has shock, whether this is septic shock, cardiogenic shock, hypovolemic shock, whatever it is, that will lead to a decrease in blood flow. If there's a decrease in blood flow, that means that you might not be able to deliver that drug as well to various different tissues of the body. So what will happen to the distribution of the drug? There may be a decrease in the distribution of the drug or delivery of the drug to the tissues. And so that's an important concept to remember, okay? Now, the other factor that plays a huge role here when we talk about a patient and the distribution of a drug to different tissues is capillary permeability. It's pretty straightforward, right? For example, I have this capillary here. And organs such as maybe the liver, the bone marrow, the spleen, they have very special types of capillaries called sinusoidal capillaries, which are extremely leaky capillaries. They got these big intercellular clefts. They got all these different types of large fenestration pores and areas where drug can easily leak out of the blood into the tissue space. Or you also have what's called fenestrated capillaries. And this would be like in the kidneys, this would be in different glands, but they also have these big fenestration pores. They don't have as many tight junctions. And so it's easy for drug to easily leak out of the systemic circulation into the different tissue spaces and easily distribute that drug. So because of that, in these types of tissues, where you have sinusoidal fenestrated capillaries, what happens to the distribution of that drug? You increase the distribution of that drug because now you have increased capillary permeability. Now, in the opposite situation where you think about the blood-brain barrier, or you think about other types of capillaries like continuous capillaries, which is like, for example, the muscles. In these situations, you have no intercellular clefts, you have no fenestration pores, you have these big tight junctions between the cells which are really reducing the ability of things to easily move out of this actual blood vessel and into the tissue spaces. So the actual diffusion of drugs out of the blood and into the tissue spaces is really dependent upon two factors. One is you need transporters, so particular types of transporters to really facilitate the movement of that drug out of the blood into the tissue. Or you need a super hydrophobic drug. Okay, in order to be able to push this drug out. It has to be super lipid soluble and very small in order for this drug to be able to easily pass out of the actual capillary into the tissue space. But theoretically, what happens to the distribution of the drug in these types of capillaries where they're not very leaky? There would be a decreased distribution. And the only way that we'll be able to get that actual drug out of the capillaries into the tissues is if they have special transporters to push them out, or if they're extremely small and hydrophobic. And I think the best example here is the brain. Now, clinically, why is this important? You know, if a patient has something called septic shock. So when a patient has septic shock, what happens in septic shock is that they have extreme increase in their capillary permeability. They actually call this a capillary leak syndrome. So whenever there's an increase in capillary permeability, what happens to the actual distribution? What happens to the actual concentration of the drug inside of the blood? So the concentration of the drug inside of the blood will do what? Well, if I'm giving the drug and distributing it to the tissues, it's leaking out of the blood into the tissues, what happens to the actual concentration of that drug in the blood? It'll decrease the serum concentration of the blood. And in patients who are septic, we want to actually have high serum concentrations of the drug so that it can work longer over a particular period of time. And so what happens is this will actually increase the distribution of that drug. And that will actually decrease the serum concentration of that drug. And so that's an important thing to remember. That's why in critically ill individuals, when we give them particular antibiotics, we actually want to give them high dose antibiotics because their distribution of the drug is extremely high. They're leaking a lot of it out into the actual tissues, which may not be tissues that we need the drug to go to. And because of that, we don't have very high serum concentrations of the drug. So whenever a patient is super septic, we have to give them tons and tons of large dose antibiotics to be able to get the concentration of the drug in the blood to a relatively high concentration to exert its effects. So it's an extremely important concept here. All right, so we got blood flow, capillary permeability. Pretty straight concept for a concept with blood flow. Increased blood flow, increased distribution. Decreased blood flow, decreased distribution. Super leaky capillaries, increased distribution. Very tight junctions, very not leaky capillaries, decreased distribution. Only way we can get the drugs out is by transporters or very hydrophobic small drugs. All right, that brings us to the next concept with factors affecting distribution, which is protein binding. This can be plasma protein or tissue protein binding, but more particularly plasma protein binding. Let's come down and talk about that now. All right, so the next part that we have to talk about is protein binding. So we went over blood flow, we went over capillary permeability and how that affects distribution. The next thing is protein binding. How does that affect the distribution of the drug, the delivery of the blood to the actual organs or tissues that it needs to go to exert its effect? Now, when you think about this, it's pretty straightforward. You know, our liver is responsible for making a very special type of protein, a special type of plasma protein called albumin. That's one of those. And then our kidneys are responsible for making sure that we don't put much of that albumin into the urine, right? So they want to maintain the albumin in the urine. Maintain the albumin in the actual blood. So whenever you have a patient who has normal kidney function, normal liver function, you should be able to prevent the excretion of albumin into the urine, and you should be able to make a certain amount of albumin into the blood. Now, albumin is extremely important because it loves to bind on to particular drugs inside of the blood. Some of them. So let's pretend for a second you have to distribute a particular drug through the body into the different tissues. If I have a drug that's extremely protein bound, so here's my drug in blue, and it's all going to be binding onto this albumin. That means that the amount of albumin that's actually inside free, not bound to protein, is very low. So in situations when you have a high protein bound drug, so high plasma protein bound drug, what happens to the actual amount of free drug then? There is a decrease in free drug. And so because of that, this is all that you have to be able to distribute or move out of the bloodstream into the particular tissues to exert its effect. So therefore, what happens to the distribution of this drug? Would it increase or decrease? Well, the amount of drug that I'm actually delivering to the tissues is going to decrease. So what happens to the actual distribution? I'm going to decrease the actual distribution. Now, one of the things that's actually really important here to remember is that whenever you have a particular drug that's highly protein bound, it's going to stay in the plasma. So this generally will concentrate in the plasma. So it'll be higher concentrations inside the plasma. Now, one of the cool things is that after a particular amount of time, let's say that this is a drug, it's supposed to, maybe it's an anti-seizure medication like phosphenytoin. Phosphenytoin is actually a pretty heavily albumin-bound drug. What happens is the free phosphenytoin will actually move out of the actual bloodstream, diffuse into the actual tissues inside of the brain, and inhibit specific types of seizure activity. What happens is, as the actual phosphenytoin is either metabolized and excreted, the concentration in a free amount of it decreases. So what happens is, some of that's actually bound to albumin will start acting as a reservoir, and they'll start releasing small amounts of the albumin over time, small amounts of the phosphenytoin into the bloodstream. And so what's really cool to remember about this high protein bound is that these things can act as reservoirs. And as the concentration of the free drug decreases, the amount of plasma protein bound drug will start acting as a reservoir and releasing small amounts of that actual drug into the bloodstream and increasing the free concentration. So that is an important thing, and it allows for the drug to be able to have a longer lasting effect. All right. In the opposite situation here, where you have a drug where very little of it is actually protein bound. Very little of it is protein bound, and tons of this drug is actually going to be free drug. So in that situation where you have a very decreased plasma protein, and I should actually important here, plasma protein, so protein binding. So decreased protein bound, and again, plasma. What happens is that you're gonna have tons of free drug. And if you have tons of free drug, you have tons of drug that can easily, because here's the thing, can albumin, here's the reason why that this is important to remember. Can this big honking albumin molecule easily cross this actual vascular structure? Can an albumin molecule easily move out of the bloodstream? No, because it's too dang big for us to be able to allow for that. It's also charged, so it's too large, it's charged, and it's hydrophilic, which means that the ability of this drug to move out of the bloodstream into the tissues will not occur. That's why the distribution of the drug is actually decreased, because it's bound to plasma proteins. Plasma proteins should not be able to leak out of the plasma and into the interstitial fluid. So the amount of free is the only one that would be able to pass. If I have a lot of this drug that is in the free form and very little of it is actually bound to albumin, now all of this can easily pass across this actual blood vessel and into the tissue spaces. So there's an increase in the actual distribution of the drug. And then again, this will actually concentrate in the tissues. Or we can say in the extracellular fluid of some kind, whether this be, this can actually concentrate in the interstitial fluid. So we'll put in the intracellular fluid and interstitial fluid. Okay, extremely important to remember that. Now, think about this clinically. If a patient has chronic kidney disease, this is why I was talking about this in the beginning, chronic kidney disease, what happens to their ability to maintain the albumin levels in the blood? It decreases. And so what happens is you start actually causing lots of albumin to be lost in the urine. So what happens to the levels of albumin inside of the actual bloodstream? What happens to it? The levels of albumin in the bloodstream will start to plummet, and you get a lot of this type of effect here, where there's an increased amount of the free drug, increased distribution, and a lot of it can concentrate in the tissues. The other situation here is if you have a patient who has cirrhosis. So if you have a patient who has some type of liver disease or liver failure, and their ability to be able to produce the actual albumin decreases. If the amount of albumin decreases, you get this situation where you have lots of free drug, high amounts of distribution, easy for it to be able to concentrate in the intercellular fluid and the interstitial fluid and exert its effects. So that's an important thing to remember, because this is how you get toxic side effects, okay? So whenever you have a patient who has liver failure or CKD, you're going to decrease the amount of plasma protein binding of the drug and allow up for a heavy distribution of the drug. And that's an important concept to remember. Okay, my friends, the next thing that we have to talk about here, since we're right here, is solubility of the drug. This is another important point. But it's actually probably the easiest one, thank goodness. You're like, dude, I can't, my brain's on fire, I can't remember as much. Don't worry, this one's an easy one for once. When you talk about solubility, again, you're talking about the ability of the drug to move easily across the actual blood vessel, the cell membrane of the blood vessel, into the interstitial fluids, and then cross the actual cell membrane of the actual cells or organs that it's supposed to distribute to. If I think about albumin, right, this determines my degree of protein binding of the drug. So if I had a drug like this, well, would this drug be able to easily pass across this tissue and then again into the cells? No. You have this big honking hydrophilic charged large protein molecule? Heck no. But if I had a drug here, the free drug, and this free drug is small. It's non-polar, meaning that it's not charged. It's hydrophobic, meaning that it's extremely lipid soluble, loves lipid. This thing can pass through here so easily and can easily distribute out of the blood into the tissues, and this would be a very high distribution. So you have high distribution of a drug whenever there is an increase in the non-polar, hydrophobic, or small nature of the drug. Now think about this again. You have a drug that's bound to albumin. High protein binding means that they're going to have less distribution of the drug, right? All right, so would this thing be able to pass here? We already said no. But if I have a drug that's like really large and it's charged, doesn't that kind of look like albumin a little bit? So if I have a drug that's super big, like albumin, it's polar, like albumin, and it's hydrophilic, meaning it loves water, hates lipids, like albumin, is this thing going to be able to easily pass? No. So the distribution is going to drop, and a lot of it will stay concentrated inside of the blood. So the ones that have low distribution will stay in the blood, concentrate in the blood. The ones that have high distribution will concentrate into the actual tissue spaces. Important to remember. Because the last concept, and probably the most important concept when we're talking about distribution, is the volume of distribution, the apparent volume of distribution. All right, guys, let's talk about volume of distribution. With volume of distribution, this is basically the hypothetical theoretical volume that will occupy a drug with respect to our total body fluid, or total body water, if you will. So for example, that consists of our plasma volume, our interstitial fluid volume, and our intracellular fluid volume. If the drug were to occupy all of these different types of compartments, it would have a very large volume of distribution. If it only occupied the plasma, it would have a very low volume of distribution. If it occupied a little bit of maybe the plasma, a little bit of the interstitial fluid, it would have some type of like medium, little bit of like a in-between volume of distribution. That's the basic concept. So when I talk about these, I want to talk about three types: a low volume of distribution, a volume of distribution that's somewhere in the middle, and a high volume of distribution. Now, if you take into consideration all the things that we talked about, that blood flow, capillary permeability, degree of protein binding, solubility, all of these things play a role within volume of distribution. Low blood flow to a particular tissue, you're going to have low distribution to the tissue. If you have a decreased capillary permeability, you're not going to distribute that blood to the tissues as well, so they'll have a decreased distribution. If you have a drug that's extremely plasma protein bound to albumin, right, what's going to happen? Then the distribution of that drug is actually going to do what? It's going to be decreased, because if you have a lot of that drug that's actually bound to albumin, that's going to be a problematic issue, because not as much of it's going to diffuse out of the actual blood into the interstitial spaces and into the actual tissues. So it's important to remember that. And if a drug is actually hydrophilic, it's very large, it's a charged molecule, very polar, it's not going to be able to leave the blood easily and get into the tissue spaces. So all of these things play a role within volume of distribution. So imagine here I take a drug here, and this drug that has a low volume of distribution will be heavily protein bound. If it's heavily protein bound, is it going to be able to move? No. There's going to be less free drug, and then a lot of it bound to the actual albumin. On top of that, whatever is free, this drug is very large, charged, and polar. Is it going to be able to easily pass through? No. If there's decreased blood flow to this tissue, what's going to happen? There's going to be decreased distribution. And if there is a decrease in capillary permeability, what's going to happen to the ability of this drug to leak out? It's going to decrease. So all of these things come into play. Now, because of that, this drug is primarily occupying only one of these three compartments. Let's say I make up a theoretical volume here, that within the plasma, that's 4 liters. Interstitial fluid, I don't know, 8 liters. And then the volume inside of the cells of our entire body cells, 12 liters. So total volume, and again, I'm just making this up, is going to be 24 liters, okay? Out of that 24 liters that this drug could be occupied in, what is it only occupied in? It's only occupied in 4 liters. So because of that, the VD of this drug is approximately somewhere around 4 liters. So because of that, this drug would be very heavily concentrated inside of the blood plasma. So this drug concentrates in the plasma. Extremely important to remember that. And the reason why it would is because it's either heavily protein bound, high molecular weight, charged, polar, also decreased capillary blood flow, decreased capillary permeability. Okay, these are big things to remember. Now, if you take for consideration here another thing, let's say you have another drug. This drug, a little bit of it is protein bound, a little bit of it, not a ton is protein bound though. So you have another drug that has some degree of protein binding, but not a ton of protein binding. It also is maybe lower molecular weight, okay? So it's not as big. Maybe it's a little bit smaller, lower molecular weight, but it's still like hydrophilic. So it still has some type of charge to it, a little bit of charge. This one's heavily charged, heavily polar. But this one's a little bit hydrophilic, not as significantly protein bound, and it is smaller. Because of that, this drug will easily be able to some degree, move out of the blood vasculature, occupy some of the actual volume inside of our interstitial spaces. So maybe it can have a little bit of volume that's in the interstitial spaces, and it can also occupy some of the volume of our plasma. So because of that, what do we say over here? 4 liters, 8 liters, and 12 liters. That was a total of 24 liters. If that's the case, then this drug is occupying two of the compartments. One is the plasma and one is the interstitial fluid. So theoretically, its volume of distribution would be 4 liters plus 8 liters, that's 12 liters. So the volume of distribution is somewhere, and again, I'm making all these numbers up, it's 12 liters. So because of that, you're gonna see this in the plasma, it'll concentrate in the plasma and maybe into the interstitial fluid. And maybe even a small amount into the actual cells, but primarily a little bit between these two compartments here. You obviously know the last one, high volume of distribution. You have a drug, and literally almost none of it is bound to albumin. So because of that, you have most of it is actually free drug. And on top of that, this drug is small. It's non-polar. It's hydrophobic, lipid soluble. You have a increased blood flow, increased capillary permeability. Tons of this drug is going to leak out into the interstitial spaces. And then tons of it is going to leak into the actual tissue cells because it's very lipid soluble, it's very non-polar. Again, it has a lot of blood flow to the area, increased capillary permeability, and not much of it is actually plasma protein bound. Because of that, this drug is occupying all 3 compartments. It's occupying the 4-liter compartment, the 8-liter compartment, and the 12-liter compartment. That means that the volume of distribution of this drug, and again, I'm just making it up, is approximately 24 liters. So this will accommodate, it'll be in all body compartments. So a part of our total body water. Now, obviously, you know, drugs can have insanely high volumes of distribution. I made these numbers up. Sometimes, to give you an example, there's a drug called warfarin. So warfarin, its volume of distribution is somewhere around like 8 liters, approximately. So it's somewhere around 8 liters. Because of that, in a real world, it's not very high. So it's somewhere around 8 liters, that's not a ton. So most of warfarin, we would consider this a low volume of distribution. That's what we would actually consider it to be. It'd be more of a low volume of distribution. So because of that, because it's a low volume of distribution, it would primarily concentrate in the actual blood plasma. And that's great because guess what warfarin's supposed to do? Act as a blood thinner. It's supposed to interact with the clotting proteins, inhibit the clotting proteins, and basically help to thin the blood out, preventing clots from forming. So that would be a good thing. That's why you would want this to actually have a low volume of distribution, because you want it to stay in the area where it exerts its effect. Think about another drug. And again, I just like this one because the volume of distribution is absolutely insane. I can't say I've ever prescribed it, but if you ever do, for malaria, chloroquine. Chloroquine's volume of distribution is about 150,000 liters. That's more than our entire total body water. And that may seem insane, but it's because most of this drug, almost all of it, none of it is plasma protein bound. It's heavily bound to the proteins inside of our tissue cells. It's extremely hydrophobic, super small, non-polar, has a good way of being able to distribute beautifully throughout all of our body tissues. So it can occupy so much volume. There's so much drug that can actually be occupied by such a large volume. So because of that, this would have an extremely high volume of distribution, which we want to exert its effect on the various tissues that malaria can actually cause problems with. So this is the big concept to understand. So again, volume of distribution is dependent upon a lot of this stuff that we just talked about. And whenever we give particular drugs, we want them to have a volume of distribution, again, particularly depending upon what area we're trying to get them to work in. All right, guys, so now let's talk about some questions that help us to really understand a little bit more about the distribution of a drug. So here we're going to talk a little bit about something called bioavailability. Remember, I told you it was a very important concept about. So we have a drug here, NN610. It's an investigational cholesterol lowering agent. It has a very high molecular weight, so it's a very large molecule, and it's extensively bound to albumin, meaning it's heavily protein bound. If you have a drug that's very high molecular weight and it's extensively protein bound, is it going to be able to leave the vascular system and go out into the tissues and have therefore a large volume of distribution? Think about it, guys. Here's our situation here. If we have something that's a large molecule, it's also very hydrophilic, and it's also heavily protein bound. What do you think is going to happen to the distribution of the drug? It's going to be very poor. So this will have a very low volume of distribution because it's going to stay in the vascular system. It's not going to leak out. If we have something that is, again, very small, it's also very hydrophobic, it's not extensively protein bound, it would have a high volume of distribution. So in this situation, what will we expect? It's going to have a low apparent volume of distribution. Why? High molecular weight, heavily protein bound, and also another particular reason is that it's likely going to be hydrophilic and probably polar. All right, let's move on to the next question here. We got a 40-year-old male patient, 70 kilograms, was recently diagnosed with an infection due to what's called MRSA, methicillin-resistant Staphylococcus aureus, so MRSA. He was given a 2,000 milligram dose of vancomycin as a loading dose for that infection. The peak plasma concentration of vancomycin was 28.5. What is the apparent volume of distribution of this drug based upon that? Do you guys remember how we kind of went about the calculations here? So we remember that volume of distribution is equal to the actual bioavailability times the dose divided by the peak plasma concentration. So if we take that into consideration here, how do we kind of go about doing this? The bioavailability of this drug is given what? IV. If it's given IV, what is that? It's 100%. That means 100% of this drug is getting into the circulation. So it's going to be 1. Then we take into consideration the dose that we're going to give them, which is 2,000 milligrams. And then what we're going to do is we're going to divide that by the concentration that we were able to achieve in the circulation after we gave this dose. And that was 28.5. So if we take 2,000 divided by 28.5, that would give us how much of the drug is being distributed throughout all of the actual compartments or volume within inside of the body. And so what does that give us then? If we go ahead and do that, we get 2,000 divided by 28.5. That gives us about 70.1 liters. So that is a extremely decently large volume of distribution here. But if we also take into consideration here that we have to have this in the apparent volume of distribution is liters per kilogram, what are we going to consider here? So then we actually have to take 70.1 liters and divide it by 70 kilograms. So then if we take that at 70 divided by pretty much 70, what would that give us? That'll give us about 1 liter per kg. So our volume of distribution in this situation is about 1 liter per kg. It's an important concept. All right, guys, so that kind of finishes off our discussion on distribution with pharmacokinetics. I hope it made sense. I hope that you guys really did enjoy it. In the next lecture, we're going to continue on with the pharmacokinetics series, and the next thing we're going to talk about a little bit more is something called metabolism and really understanding that, and we'll do some cases there. So I hope to see you guys there.